Good afternoon, everyone, and welcome. My name is Meg Dorsey. I'm a CIC board member and the current chairperson for the CIC Education Committee. I have the pleasure of being your moderator today. The California Immunization Coalition hosts education hours and emerging issues conversations throughout the year on immunization-related topics to help our colleagues stay up to date on important news and information in the immunization world, which is always a lively place to be. As part of the immunization community, you have probably heard the saying, well, if you've seen one flu season, you've seen one flu season, because as we all know, flu seasons differ widely each year. For today's program titled Respiratory Season Viruses, we are fortunate to have Dr. Jeffrey Silvers to update us on the specifics and the unique challenges of the 25-26 flu and respiratory season. I want to take a moment at this time to thank the CDPH for their ongoing collaboration with the CIC on many important immunization-related topics. Our objectives for today are as follows. We will understand the potential impact of the upcoming influenza season. We'll learn about early data on the vaccine match and the role of vaccination. And we'll understand the over-the-counter testing protocols and guidelines for oseltamivir or Tamiflu treatment. And now for our usual hopefully quick housekeeping info. For today's webinar, a recording will be available on the CIC YouTube channel website. If you're not familiar with the CIC YouTube channel, I encourage you to check it out and to find an archive of this program where slides will also be available, as well as previous education hours and emerging conversations programs. And while you're on the site, be sure to subscribe. As a reminder, all participants will be muted throughout the program. If you need technical assistance, please use the chat section and see the chat box for following instructions that can help you troubleshoot any technical issues that you're having. We will hold questions until our speakers have both presented, but please feel free to submit your questions using the Q&A box at the bottom of the screen at any time during the program. And now it's my pleasure to formally introduce our speakers for today. Dr. Jeffrey Silvers is the Medical Director of Infection Control and Pharmacy for Sutter Health, where he serves as a physician lead in antimicrobial stewardship, infection control, epidemiology, emerging infections, and pharmacy for the healthcare system. Not a small job. Dr. Silvers works closely with the California Department of Public Health, having served on multiple advisory committees. After completing his medical training in the UCLA healthcare system, he spent 35 years caring for patients with complex infectious diseases. He's on the board of directors for the Infectious Disease Association of California and currently serves as the vice chairperson for the California Immunization Coalition. He is also the lead author of the widely read Sutter Emerging Infections newsletter. Dr. Silvers, we are delighted to have you with us today, and thank you. In addition to Dr. Silvers, we are grateful to have Teresia Gamboan, a master's prepared health educator at the California Department of Public Health Immunization Branch, and she will speak after Dr. Silvers. Teresia will share the creative and helpful resources produced by CDPH to help us communicate the importance and urgency of getting flu vaccinations this season and every season. And now I would like to invite Dr. Silvers to begin his presentation. Thank you, and the mic is yours.
Thank you very much, Meg, for that wonderful introduction. And thank you, everybody, for joining us today. So we're going to talk about the respiratory season viruses, and I have no conflicts of interest. So mainly we're going to focus on influenza today. Almost the whole talk is influenza, but why not COVID-19? Well, here's Sutter data comparing 3 different years, and the orange represents the percent positivity in ambulatory, that run line there, and you can see, and then the blue represents the emergency departments, and they peak and trough about the same times. Notably, these 3 mountains are summer, spring, outbreaks, and then the smaller, very small one here, and almost non-existent one, those are winters. We only had 46 positive tests out of 4,000 tests. The week ending November 30th and the week ending yesterday, we had the same number. And so you can see we have almost no COVID. RSV, again, rates are very low right now, 2025, 64 cases. 2024, the analogous season, we had 4 times as many. And in 2023, we had almost 10 times as many. So we're not seeing a lot. But if you look at the CDPH graphs here, and I just updated this today, you can see from this blue run line, we're starting to see more RSV. But if compared to the prior 2 seasons, it's nothing exceptional. So we're going to focus on flu. So we're going to talk about H3N2 subtype K. Okay, so here's a picture, a drawing of what influenza looks like. Now, what is notable about the influenza virus, besides it has 8 RNA strands as segments rather than a single one, is you have all these blue spikes, which represent the hemagglutinin, where the organism binds to the respiratory cell. And then you have these orange spikes, which are supposed to represent the neuraminidase, where the virus escapes from the cell and then goes and infects other cells or sheds and causes spread of the disease. But actually, that's not the way it looks. I mean, that's the way it looks like in the picture books. But this top electron micrograph makes it look more like a millipede than it does like a sphere, although obviously much, much smaller. And all these spikes here, rather than alternating hemagglutinin neuraminases, these are all hemagglutinins. And it's only at the very tip. You have a little bit of neuraminidase. And you have so much hemagglutinin that it's very hard for the antibody to prevent the virus from attaching to the cell. And so it can cause infection, even though we have antibodies from the vaccines or previous disease. Once it gets and attaches to the respiratory cell, it gets inside and it breaks down by a process called schizion, kind of like scissors, and then they become the sphere that you see. And these small spheres are easier to transmit from cell to cell. And although they're more susceptible to the antibodies, it still transmits. So you can end up with milder disease, and it's easier for the vaccines to prevent you from having severe disease, but it's very hard to have enough vaccine to prevent infection completely. So I mentioned that, and so I'll just move on to the next step here. So in Science in 2013, a doctor named Cole presented data that suggested that there's only 9 different amino acids. You know, proteins are made out of amino acids, and the hemagglutinins have sugars on them also. There's only 9 little amino acids that determine whether or not the hemagglutinin can escape the vaccine antibodies. Very small area. And from 1968 to 2003, there was only 1 amino acid change per year for like the H3N2 that would enable to escape the vaccine. And then after 2018, up until 2020, when COVID came along, they started seeing a couple of mutations. And now we're starting to see 2 and 3 changes. And so again, the virus is adapting to be able to escape our immunity. So I'm trying to get to subclade K here, because that's really what's making the news. So we've had last season, we had a terrible flu season last year. And ours was mostly H3N2 and H1N1, same as Canada and Europe. But most countries, for example, in Asia, they just had H1N1. And the H3N2 is dominated by a subclade called J.2. And then during the Northern Hemisphere season, it had a couple more mutations, which then went down to the Southern Hemisphere, to Australia, because their winter is our summer. And they were seeing what we were, and then they got a 3rd mutation. So that was late in the hemisphere. All of a sudden, this variant went from less than 5%, or subvariant really, to almost half of all isolates. It got this 3rd mutation, and now 3 mutations in those 9 critical amino acids, that it could really escape the immune system, maybe virulent, who knew, transmittable for sure, and anticipate reduced protection from the vaccine. So instead of calling it J.2.4.1, the next letter in the alphabet is K, so they renamed it subclade K. Don't ask me about A through I, we're just on J and K right now. So I mentioned how, who's a horse and who's a cart. So Australia got what we had last year during this last summer, and now at the very end of their season, they had another variant form, which is now K, which is going back to our season. Australia had the worst season ever recorded, and they have poor vaccine rates. So this shows the kids 6 months to 5 years, and usually they have about 25% of that age group. And so, yeah, you get a bad strain, they're going to have a bad outbreak. And even people 65 and older, they only have 50%. So they don't have a very effective vaccine program. So why am I talking about all this? Well, here's what made the news recently. Japan and the United Kingdom, Great Britain, started seeing a very early flu strain. And here's what was coming in the news. Okay, could be a big problem, could be a harsh flu, could be nasty. And so a lot of news was coming out. It could rival last year. And last year was a really very difficult season and a lot of deaths. But you know what? It's really too early to know. It's still possible, but it may not be as severe. It may, if we're lucky, be more like a typical season. So let's see what the data shows. So this was last year again, and look at this. Hospitalizations up to 1.3 million at the upper end of the estimates, with maybe as many as 130,000 people died. We know we had over 200 children die, and 80% of those were unvaccinated. And it's very problematic. So if they're looking at the flu-related hospitalizations by week, here's last year. This is cumulative, and you can see that somewhere between 600,000, 1.3 million, which was much higher than other previous seasons here, where you can see the numbers. It was sort of the lower end of the estimate is 20. It was at 27, 2018, but otherwise this was a severe season. So we understand why people are worried about it, and they should be worried about it. And so now we're going to say, okay, so what's happening with subclade K? So what happened in Japan? October 4th, they announced that their flu season started. It was over a month earlier than last year. It was the second earliest in 2 decades. And all of a sudden, they're seeing 3 times as many cases as they saw last year. By the way, last year was a bad season. Okay. And then what they noticed middle of October, so it's, almost 2 months ago now, they had 300 people hospitalized, notably kids. Half of the hospitalized were kids. And then as of the week of ending November 16th, again, about 4 weeks ago, 6,000 schools were closed. Well, that sounds pretty scary. And the week ending November 23rd, they had almost 200,000 cases. Notably, almost all were young people, okay? And the H3N2, the subclade K, is the dominant strain. So what's coming up in the United Kingdom? Well, here they are, and this is the percent positivity, and here they are in the end of September, and all of a sudden, whoa, what is going on here? This is a rapid ascent. We're seeing a lot of cases, and much earlier than we had in the last 2 seasons. But all of a sudden, and by the way, most of them were highest in kids 5 to 14 years of age, then all of a sudden took a little blip here. And this is really important to me because it looked like it suddenly got up here and then maybe it readjusted. And now it looks like it may be more similar to what we had the last 2 years. It turns out that the amount of disease in the United Kingdom is increasing. They're not talking a lot about hospitalizations or mortality. They're talking about a lot of disease in young people. Hence, think about the vaccine. Here's the latest with the CDC data. And this is influenza-like infection. This is not actually people who have necessarily influenza. They have to have a fever and a cough, or a fever and sore throat. And you can see most of the country is in this range here, low to minimal. Louisiana is the one that was the first and the highest to report substantial amounts of influenza. We'll talk about that in a minute. Colorado was second, New York City, and of course, New York State. and then New Jersey here. And basically what happens is we have a few jurisdictions that have very high levels. The rest of the country is not seeing much yet, but it actually is starting to increase. I do want to put a little aside here because Ralph Abraham was the leading medical advisor for the state of Louisiana. Remember the state right here that has highest outbreak of influenza? Last year in February, he decided that he was going to officially end all vaccine clinics. Now, that's when we were having the big outbreak. And he would no longer promote vaccines in the state of Louisiana, and he removed all accessibility to links on the websites at the state that would enable people to figure out where to get a vaccine. Then last September, when they had a pertussis outbreak in Louisiana, he didn't tell anyone until the second child died in the early spring in 2025. And a reporter found out, investigating, and noted that they had the biggest outbreak in years in Louisiana. And the reporter called the Surgeon General on that. And again, it took him another 3 months after that before they even told anybody. He's now second command at the CDC. Okay, so let's move on to flu again. So here's a positive test as of the end of November 30th. I unfortunately didn't have time to update all the tables this morning, but I can tell you that at Sutter, we're up to about 140 tests this week that ended yesterday compared to a week ago ending November 30th when we had 86. So we're starting to see more. So flu's starting to show up. So this shows the three sequential years. The green is emergency department. The first number is the number of positive tests. In parentheses, the number of tests performed. You'll see November 30th, we had 71 positive tests in the ED out of 3,600. The prior year, the same time, basically 220 tests, about 3 times the positivity rate, same number of tests performed. And that's just our big season, but we hadn't started a big season last year because in 2023, we had 5 times as many positive tests as we do now, and ambulatory see something similar, and then total number of positive tests out of the number performed and the percent. So you can see flu rates as of November 30th are very low compared to last year, and even remarkably low compared to 2023. So we're not going to have an early flu season, that's for sure. And it may not even be an average onset. It may be just a little bit later than usual, which is kind of what we're seeing. That doesn't tell you how bad it's going to be, though. Okay, so the vaccine doesn't match. If it doesn't match, why are we getting it? If we have a new subclade, is it going to match? H3N2 is always the most difficult strain to match for multiple different reasons, which I'm not going to go into right now. And so we frequently don't have a great match. Now, what is a great match? I mean, let's figure this out. I mean, I wish, as I showed you, because of the filamentous form of the influenza virus as it first attaches to the host cell, it's almost impossible for us to have enough antibodies to prevent people from getting infected. Okay, something has to change. Either we have to attack, we have antibodies to different parts of the virus, but doing the way we're doing it, it's not going to do that. But does it prevent going to ED? Does it prevent severe disease? Does it prevent hospitalization? Does it prevent death? That's honestly what we have to look at. And you know what? It does do that. So what about some data? So Urine Respiratory Review, and I've got a link down here if you're interested in it. They recently published a systematic review and a meta-analysis of almost 200,000 patients worldwide, 39 countries, 20 years of data. Okay, now during that 20 years, we know vaccine match varies. Okay, they looked at 119 articles. That's a large number of articles. Most meta reviews do, 7 to 20. This is a huge study. And then used another data set that include information over 6.5 million people. And the data was divided into 3 age groups, less than 5, 5 to 64, 65 or older. And what did they find? Okay, so they looked at 1-year mortality in children less than 5 years old. Okay, H1N1 is this pinkish one here. The blue is H3N2. Influenza B is the green. And this is the odds of death comparing vaccinated to unvaccinated children infected with one of the strains over 20 years. So vaccine match has varied so much. And what does it have? What do we see? Okay, your chance of a 5-year-old dying from flu, if they're vaccinated, it is H1N1, is 40% the chance if they're unvaccinated, 60% reduction. The chance of dying from H3N2 is 30% less. I mean, it's 70%. It's the risk ratio is 0.3. It's a 70% reduction. And the odds of dying from B is down by 80%. Now, kids under the age of 5 rarely die from B, so I don't know what that means, but these mean a lot. And the children that are vaccinated have a lower mortality. And when you look at last year, the 200 kids that died, the huge number that died of CNS disease, way more than half were unvaccinated, and 80%. And of the kids who died of CNS disease, nervous system involvement, half of those kids had no risk factors for anything. They were just normal but unvaccinated children, and they died. So what about all ages? Okay, so this is really important when you talk. I'm showing this data because this shows that the vaccine works. And then how long does it last? Okay, so again, the pink is H1N1, and the blue is H3N2, and the green is influenza B. Okay, if the vaccine does not provide any protection against mortality, then it's at this dotted line here. And this is how many months after you've been vaccinated. Okay, so let's focus on the blue here because that's what we're seeing the most of. 1 month, 3 months, 6 months, statistically significant, lower risk of dying, all ages. 9 months, almost statistically significant. So the vaccine prevents dying even when it's not a good match, for up to 9 months, likely 9 months, because it's almost statistically significant at 0.067. That's good. I mean, it's perfect? No. And the same thing with the H1N1. Okay, it goes 6 months, and then it kind of reaches borderline statistical. Okay, it's still good. Influenza B, not so much. And it's, it has to do with multiple subclades of influenza B. And it's interesting. I thought it would have been a better match, but I'm okay with that because the pandemic and the worst outbreaks are influenza A. And so this is a take home. And by the way, this data was collected before all ages. This was before they were using enhanced vaccines on a lot of adults over 65, either the adjuvanted or the high dose or the recombinant. Okay, so this is great. Okay, what about England's data on subclade K? Let me check my time here. I'm doing okay. So this is a peer-reviewed article published November 2025, and they're looking at the subclade K and the vaccine they're using this year. Now, they use predominantly recombinant or cell-based vaccines rather than the egg-based, which we use predominantly, for people from 18 through 64. And of course, they use enhanced vaccines, which include egg-based over 65 and older. And then 2 through 17, they preferentially use the live attenuated, the flu mist influenza vaccine. Okay, what did they find? And this just kind of lists this. Here's what they found. Vaccine effectiveness against being seen in ED or admission with influenza A or H3N2 specifically, as subtype of A, 75% in kids. In adolescents. Again, they're using live attenuated influenza vaccine, flu mist, but it's the same strain as our regular vaccines. All adults 18 and older, again, the critical stuff, it's about 32 to 39%. Is it great? No, it's not great. But it still means 1/3 of the people will not need to be admitted. The others, you know what? The disease is not as severe. And you know what? I can live with that. I wish it was better, but if it prevents me from being in the hospital, prevents me from dying, I'll take that. And that's why we'll talk about treatment a little later. Okay, so the take-home on flu vaccine. I mentioned it's very hard to match. It's still likely to prevent that you'll need care in an ED or admitted to a hospital. Data from England says that the vaccine effectiveness in children is like incredible. I don't know that it'll be sustained, but that's great. And it's kind of typical in adults. And I mentioned what they use. And again, everyone 6 months or older, including persons planning pregnancy, pregnant, postpartum, or lactating, with rare exceptions, should be vaccinated against the flu. End of story. Okay. I don't know if everybody, I don't know how many people on this call have taken care of a pregnant woman in her third trimester where she got influenza and lost the baby. And I have, and it's just tragic, near term. Okay, let's quickly go through some flu medicines and we'll talk about this because I can't prevent all infections, but can we help those people who do have infection? Okay, so neuraminidase inhibitors. The Tamiflu is the most common one by far. And the question is, does it work? People say, I take it, it doesn't work. And the data said, the FDA said you can take it anytime up to 48 hours. And if you're a normal host, and anytime after you get sick, if you have this multitude of problems, but it doesn't work that way. So here's a study that was done. And they had 1,400 participants, but then when they with ILI, influenza-like illness, but 950 of them actually had flu. And if they were treated within 6 hours of onset, within 82 hours, within 82 hours, they had felt normal for 24 of those. Normal. So you're talking about less than 60 hours of illness. Okay, that's 2.5 days. If they wait more than 36 hours, it's 180 hours minus 24. It's what, 156 hours? 6 days before they feel better. And so you can save 3 days. Here, you got 72 hours less if you give them Tamiflu within 24 hours of onset. 180 minus 111, okay? 70 hours less, basically. It's 3 days of less illness if you take it within 24 hours. If you take Tamiflu more than 24 hours after you get sick, doesn't do much. Why is that? Well, you know what? Tamiflu, which is just, I showed you that filamentous strain, it's not all over the virus, it's at the tips. And it is to allow the virus to go to other cells and infect the cell and to shed it. Okay, it actually, you stop shedding normally within 2 to 3 days if you're a healthy host. 2 to 3 days. Well, if you don't start taking it until you've been sick for 2 days, it ain't gonna work. So it's very dramatic in people who take it the first day. Here's a huge list by the CDC, shortened by the medical letter, of people at risk. And so they're at risk of having severe infection, but Tamiflu will only work if they're shedding longer. So somebody who's obese isn't actually at risk of shedding the virus longer. They're at risk of having more severe infection because they can't take deep breaths. And women, and then these various races and ethnic status, they're not at risk of shedding the virus longer. They're at risk of having more severe disease. So again, Tamiflu works in the first 24 hours here and can work longer if you're at risk of shedding it longer. So if you're immunosuppressed, people over 65, because of immunosenescence, where our immune system just doesn't work as well, we probably shed longer. And then children less than 2. So those groups, it makes sense to offer Tamiflu for 3 days. Okay, it doesn't make sense endlessly. Okay, so there's lots of stuff going on. You could get a home test. And over the counter, it's a good test. It's a flu-COVID combination test. It has about 8% false negative, but once flu starts circulating, which is going to happen the next couple of weeks, it's not going to have very high false negative results. And if you have a prescription at home or you talk to someone and you get oseltamivir quickly with the onset of the fever and the headache and the myalgias and the fatigue and feel like you got hit with a Mack truck, you can be better quickly. If you want to wait an extra day or so, not so much. Okay, I'm working with the state. I'd like to have this accomplished at all the skilled nursing facilities, long-term acute care, and boarding care, where they stock Tamiflu and do testing, and so they can test and treat and get these people better rather than clogging emergency cares and having them end up sicker and being admitted and higher mortality. In Sutter Health, we are going to be doing this at all urgent care walk-in clinics, ED, for all people who are candidates. Within 24 hours of symptom onset, or within 3 days, if you're immunosuppressed, you're over 65 or less than 2 years of age, we're going to advertise that. And then people who are admitted to hospitals with influenza pneumonia as a primary diagnosis, I would assume they're longer shedders also. Okay, so this is a retrospective study here, and the question is, if you started on hospital day 0 or 1, does it reduce mortality? And the answer is it does a little bit, less than 2%. The problem is, and this was a well-published study, and I put this up just so people understand. You have to be able to read the literature and understand it before you don't just read the abstract and say what it says is right. They didn't look at vaccination status. And anybody who was in the hospital, day 0 was admission, day after that was day 1. Anybody who was in the hospital on day 2, they could start Tamiflu on. And so a quarter of the people got it. So it wasn't a very good study, but it still showed improvement. Okay, I just mentioned this both for the educational and the scientific aspect. So we need to step up our game. Well, vaccinate. I don't know how many times I need to say that. It really is important. Wash your hands, mask in public places, cover your cough, stay home when sick, and early diagnosis and treatment with oseltamivir. So I want to quickly go through COVID and just talk about BA.3 because, is that the next big thing? BA.3.2. And before I do that, I want to talk about the durability of the COVID vaccine. And right now, what we have circulated, have for quite a while, is JN.1. And the study here, which was in JAMA at the end of October, looked at a Nebraska cohort. Well, 12% received the updated booster. And they adjusted for times as prior vaccination, prior infection, multiple risk factors, social economic status indicators. They had to be at least, so DEI stuff, they had to be at least 2 weeks away from that updated vaccine before it was counted as being there. They found that it was most protective after 4 weeks, and protection was similar to all previous vaccines for a few years now. And again, effectiveness against infection, emergency department visits, about 45%, nowhere close to 100%. 58% effectiveness against hospitalization or death. That's what I needed to do. So I think this is similar to what it was. It's not that far off from a good influenza vaccine. And then I want to talk from and I should mention, you have to put a slide in here. When people ask me, well, what about healthy people getting an updated shot, vaccine, immunization? Okay. I say yes, and I'll tell you why. It's all about long COVID. If you have an 18-year-old son or daughter who is otherwise healthy, they get COVID, they're going to feel fine. Okay. Even though the rate of long COVID is lower now, let's say, and they're saying the estimates now are 3 to 7% because people have been vaccinated, previous disease used to be thought to be 20%. There's no diagnosis, and that can totally change their quality of life. They lose concentration, they have problems sleeping, their grades may drop. You're thinking that they're just a teenager who's acting out. Guess what? They can have long COVID. I don't have a test for it. I don't have a really great treatment either, but I do have a prevention strategy, which is get these people vaccinated. It isn't about whether they get a little syndrome. It's all about long COVID. Okay, so what about this variant of interest? So the World Health Organization Vaccine Advisory Group is trying to figure out what we need for next year's vaccine. And these are some of the things, the JN.1, which is pretty much what everything's off now. This is our most recent updated vaccine strain. That's the most common recombinant. but that's fine. But they may mention a BA.3.2 as a potentially emerging new variant. So it was first identified in South Africa a year ago. What's notable about it is it has 50 mutations in the spike protein. The spike protein is like the hemagglutinin of flu. The spike protein is the hemagglutinin equivalent of COVID. And what's important about this one is that it goes back to BA.3. Everything we're seeing now is off of BA.2. Ever since we had Omicron, it's been off of BA.2. BA.1 didn't do much of anything. BA.3, it has 50 new mutations, and it has 44 distinct from our most recent vaccine. So questions are infectivity and virulence. Do I know? No, I don't know. We have limited data? And so here's what the CDC is showing that's circulating right now. They don't do a very good job of updating this. They don't get a lot of specimens because they don't want them. So very little genotyping is done. And they, instead of weekly reports, they give it out every 2 weeks, but then during holidays, it may be every month. And so it's inconsistent and frustrating. XFG is this blue here. That's a recombinant. I'll show you about that. The vaccine works against that. And actually, the vaccine works about all this stuff here pretty equally. Doesn't have anything about BA.3. Now, maybe we're not seeing it. Maybe you're not being recognized. We clearly have so little COVID, I wouldn't know. Here's the Pango lineage that the CDC publishes, and here's a link to it. And everything is off of BA.2. All of this stuff here. Here's the JN.1. Here's our new vaccine strain. And then over here, we have the XFG, the dominant strain. Here's right here. And so it's a variant. But BA.3 will be, here's BA.1. It will be somewhere down here. Totally away from everything else. So no, I don't know what it means. But that's why this raising concern. So I just have a couple one last slide here, just some conclusions. H3N2 is causing a lot of outbreaks. It's just beginning in the United States and Canada. Children and young adults are affected the most, even though it's transmissible. I'm not sure about the virulence, although it is increasing still. Oseltamivir, give it the timings, everything. And SARS-CoV-2 looks like a spring-summer virus, nothing new on the horizon. And that's it. Thank you. Back to you, Meg.
Cameron, I'm trying to put my video back on and I'm unable to, so I'll just proceed. Thank you so much, Dr. Silvers, for a wonderful, very interesting presentation, and I'm so glad that I've gotten my flu shot. And now I would like to invite Tarisha Gamboa from CDPH to share her presentation. Thank you so much, Tarisha.
Thank you, Meg, and thank you, Dr. Silvers. Appreciate it. Once again, I'll be sharing some resources and campaigns from the California Department of Public Health Immunization Branch to also supplement Dr. Silvers' presentation. So on this first slide, I wanted to share some general respiratory resources. So here, and just as a note, I just want to say I provided links which are underlined and images for each of my resources on these slides. So just wanted to mention that before I get into it. So our CDPH website has a respiratory viruses hub, and this webpage is shown here on the right-hand side. This hub contains key highlights of up-to-date activity of circulating respiratory viruses such as seasonal flu, RSV, and COVID-19. And you can use the locator tool at the bottom of this page to see more closely rates in your community. And then there's also a navigation bar with these circles here for guidance on vaccines, what to do when someone is feeling sick, and then also some more information for healthcare professionals. And then here in the bottom, we have a general respiratory resource from the new West Coast Health Alliance. respiratory virus immunization recommendations. So that's the table below. And this is general guidance on all three COVID-19, flu, and RSV immunizations. And you will see information for all of those eligible for each of these immunizations. So please refer to this guide in your practice throughout the season. Next slide, please. All right, so now moving on to flu. To help with improving flu vaccination rates, our CDPH provider website called EasyIZ has tips for speaking with parents about flu vaccination, and that's both in English and in Spanish here on the left. And these have been updated for the 2025-26 season. So please use these talking points to help address common flu vaccine concerns among parents and patients. And then we also have on the right, I'd like to highlight a respiratory disease page on EasyIZ. So this is for providers once again, and this is a landing page for all flu and respiratory immunization job aids, communication tools, and promotional flyers for patients. These resources focus on flu, but they also include co-administration for COVID-19 and RSV immunization. Next slide, please. Next, I'd like to go over promotional materials for vaccines this season. So here we are highlighting this fun superhero flyer for children. You can download this on our EasyIZ website in English and Spanish, and this is great to pass out or post in patient rooms and just encourage pediatric patients and parents to get both flu and COVID-19 vaccines. And I just want to mention for all of our promotional materials, in case you are not familiar with our materials, you will see, as shown on the link on the bottom, that each material corresponds to a label of IMM and then a number. So then this is IMM 1443. So that's why you'll see those in parentheses. But yes, we have these in English, and the Spanish version is on here as well. Next slide, please. So here I'd like to share materials for flu prevention this season. This is the Guess Who Needs Flu Vaccine promotional flyer on the right. And then we also have the flu prevention tips here at the bottom with some nice graphics on how to stay healthy this flu season. And these are some of our very popular flu vaccine materials that are printed out and downloaded, and it's for all ages. And just like Dr. Silvers mentioned, these are really great to remember to make sure to prevent the flu this season. Next slide, please. And here I'd like to highlight other ways to promote flu shots. We have these I Got My Flu Shot stickers that you can download from EasyIZ and print out with these labels linked here. And we have provided these to encourage clinic staff to wear them in the office to promote to patients and parents to get up to date with their flu and other respiratory immunizations. So we really want to promote any way you can remind those around you to get vaccinated for the season. Next slide, please. Great, and now I'd like to share some CDPH toolkits found on our CDPH website that you can utilize within your practice and promote at this time. Our Office of Communications has updated toolkits that contain messaging, images, and some videos to help with promoting vaccination. So it's always good to have these on hand for messages and reminders for vaccination. Starting on the left is our updated flu toolkit, and then our RSV toolkit, and last is the general respiratory prevention toolkit. So check out all of these on our CDPH website and keep promoting these immunizations. Next slide, please. So now I'd like to share some additional flu and respiratory disease materials from other trusted organizations. The National Foundation for Infectious Diseases, NFID, has a resources library where you can look up specific diseases and populations to find articles, media, and promotional materials on vaccines to disseminate information to various audiences. And then at the bottom, there is a helpful New England Journal of Medicine article that has recently been published explaining ongoing peer-reviewed evidence supporting the safety and effectiveness of immunizations against influenza, COVID-19, and RSV into the 2025-26 season. So this is really helpful for healthcare professionals to understand, and it reiterates the need to continue to strongly recommend vaccination to patients. So check those out. Next slide, please. And lastly, I would like to share a couple campaigns for this respiratory virus season in which you can also participate. The first one is the 2025-26 NFID Respiratory Seasons News Briefings. So this is a webinar series with live Q&A and resources to focus attention on the importance of preventing and treating flu, COVID-19, and RSV, along with pneumococcal disease. This year's theme is It's on Us, which aims to educate, engage, and empower the public and healthcare professionals to navigate these unprecedented times. And you can register for upcoming webinars and see previous recordings and infographics and other resources on this page. And then the second campaign I'd like to share is National Influenza Immunization Week, which is a national and annual observance the first week of December. This just ended last week, but it's not too late to promote flu vaccination to patients and the general public. There are a lot of media resources on this, which NFID has taken the lead on, and we at CDPH have also sent out a message to our California providers to take part in this observance. And so we hope you can continue participating in promotion and administration of flu vaccination as well. This is my last slide, so thank you so much for your time and thank you for all that you do to help Californians stay healthy. So we'll go ahead and start the Q&A and I'll pass it to Meg. Thank you.
Thank you so much to both of our speakers today. Really interesting presentations. So we will now start the Q&A portion of our program. We've received several questions in the pre-phase of the program, and we'll try to get as many questions as possible answered today, and we may combine questions of a similar nature just for efficiency. If you haven't done so, please type your question in the question section. It's a little easier for us to have you put it in the question Q&A section versus the chat, and that's at the bottom of your screen. If you have any technical difficulties, please feel free to use the chat and we'll work to assist you. We'd also like to remind you, and this is pretty important, an evaluation will pop up on your screen just after the program concludes, and we really appreciate your responses. The CIC produces 3 to 4 education hours per year, along with several emerging issues conversations, and we really rely on your feedback for identifying topics of interest and also to improve our programs going forward. So we have many really wonderful questions today. So let's go ahead and start with this question. And this has to do with your comments, Jeffrey, Dr. Silvers, about you're in the Sutter system, you're making Tamiflu available much more quickly. So considering the benefits of Tamiflu early on in the diagnosis, is there discussion happening about making Tamiflu more available over the counter? Because as you know, getting a diagnosis, getting a PCP to call in your prescription, having the pharmacy get it ready, it takes some time. So is there any way that this is being expedited for those that may be not in long-term care facilities in the Sutter system?
So that's a great question. So Journal of Infectious Diseases about a month or so ago put a symposium on influenza. And one of the articles in there is a time for oseltamivir to become generic and over the counter. And my answer is I believe the answer is yes. It's been around since 1999, so 26 years. There's very little resistance that develops to it. And so very, very little. And it's been almost only H1N1. And so I think in terms of safety, medication interactions is good. You can take it with or without food, although some people get nausea the first 1 or 2 doses. So with food at that time is good. So I think the answer is yes. At Sutter, we talked about it, and I was going to do something. I just don't think I could get it together in time with what I'm working on with the state and the urgent cares and the EDs. My plan was to, and it will probably happen next season, is send out letters to certain at-risk groups and say, you know what, you're at risk, and we would like to offer you a prescription for oseltamivir to have at home with instructions for when you should take it. I know the shelf life is many years. And so like people over 65 and for sure immunosuppressed people and stuff. So that's a goal. So I envision that in 26, 27, I'd like to see it go over the counter or behind the pharmacist point. And then you have home tests now, which can really help. Sorry it took that long to talk to that, but yeah.
That's great. Thank you so much. So I'll move on to the next question. We've had this from a couple of attendees. Are there risks to having a mother in her third trimester take the flu vaccine?
Well, we've got how many decades of experience that I think I can say no to that. I can tell you that there's risks to a mother getting influenza during the third trimester, and that includes premature delivery. It includes fetal death. And I've seen it, and it is terrible. And I'm an infectious disease doctor. I'm not an OB/GYN doctor. And yeah, I've seen it. And then taking it at least 2 weeks before delivery has the advantage of letting the antibodies form and crossing the placenta to protect the newborn baby, which is not, the baby is not eligible for vaccine until they're at least 6 months old. And babies, infants that get influenza in the first 6 months of life, it can be devastating. And so, no, I don't see any downside to that. I feel very strongly that that makes sense.
Thank you. And here's a question about testing. And this has to do with your reference to the over-the-counter test, the dual test for both COVID and influenza.
Yes.
So the influenza rapid test usually comes back very quickly, but one of our participants has noted that it often takes 3 to 5 days for a COVID test to come back positive. So what's the approach for early testing when it takes those extra 3 to 5 days to get a positive test?
You're doing the wrong COVID test.
Okay.
Okay. So we have available, I think there's around 5 different products, plus or minus a couple, that are approved for home testing of flu and COVID. And the Heliogen, and I don't have anything to do with the company, is the only one that's FDA approved, but there's several other products in a range of 3 to 5 others that are EUA, emergency use authorization, have had for multiple years, that are for flu and COVID. You get the results at home within 15, 20 minutes. They're not molecular tests, they're antigen or related to antigen tests, but they're good enough, especially when something's circulating.
Thank you. And Teresa, I have a question for you. One of our participants asks, does CDPH have a good tip sheet on talking with parents about COVID vaccines for their children, especially in this very confusing, changing time?
Right. Thank you so much for that question. And Meg, I actually just put a website in there for the participant who asked that as well. But I did want to verbally say that we do have on our EZAZ website COVID-19 specific resources. And we also have a general vaccine safety talking points that are generalized for all vaccines, but specifically with COVID, in this respiratory season, we are reviewing that webpage to make sure it's current and up to date. So I inputted that in there, and it has accessibility for everyone, not just the person who asked the question. So hopefully everyone can check that link out. And then I also wanted to mention, some other trusted organizations that we partner with are AAP, AAFP, again, the West Coast Health Alliance. We've all teamed up to make sure that we're providing the most accurate information and that's helpful to all of our providers. During this time, there's a lot of vaccine hesitancy, unfortunately, and a lot of questions. So hopefully that helps.
Yeah.
Thank you. And
absolutely. Yes, thanks,
Yes.
Dr. Thorne.
And I think we have time for one more question. We'll see how this goes, but we have a question for Dr. Silvers about the LAIV or flu mist. It's currently recommended for use in adults without contraindications. Is it especially useful? It may be especially useful to those folks with needle phobia. Any changes anticipated in recommendations for use of LAIV in adults?
Well, the most important change, which is a huge one, is it's available without seeing your doctor. You go to the flu mist site, and They have a special site there where you can answer a few questions and get the vaccine shipped to your home. They have a pharmacist who signs it. It's a great option. That's talk about something that should have been available years ago. That methodology is great. So I recommend that strongly. Obviously, you can't use that when you're pregnant. You can't use it if you're immunosuppressed. But if you're healthy, less than 49 years old, I think it's 2 to 49. It's a great option. There was some, just in closing, relate to that, there was some data on it not working as well, but they fixed, that was quite a few years ago. They fixed that since 2018, have not had problems. So I trust it.
Thank you so much. I think we're out of time for questions. We will do our best to address any unanswered questions following the program. And for those of you who asked for repeats of some of the comments that were made, I'll refer you again to the CIC YouTube channel where you can quickly review the Q&A section of the program because we're out of time. So sorry. So I'd like to thank our speakers again. Thank you to both Dr. Silvers and Teresha for terrific programs full of information. I'd also like to thank Cameron Lawton, our program manager and technical guru, as well as the members of the CIC Education Committee who provide support in planning and coordinating the call. And also thanks to all of you for spending the hour with us to get these important updates and recommendations. Quick reminder, there will be, please complete the evaluation that will pop up on your screen automatically when the program concludes. And please let us know what you thought of this broadcast and any suggestions that you might have to help us improve. And links to the webinar, as well as I mentioned, past webinars are available on our YouTube channel. And if you have, somebody also asked about slides, you can refer to the YouTube channel to see the slides from this program as well. Our next CIC webinar will be announced via email in our monthly newsletter. So keep your eye peeled for a couple of really interesting education hours that we have coming up for early 2026. And I'd like to thank everybody again for joining us today. I wish you a happy holiday season, and I hope you have a wonderful rest of your day. Thank you so much, everyone.